Good afternoon and welcome to our webinar entitled Introduction to the Revised Federal Nursing Home Rules. What's in, what's not? I'm Robin Grant, Director of Public Policy and Advocacy at the National Consumer Voice for Quality Long-Term Care, or Consumer Voice for short. For those of you who may not be familiar with us, we're a nonprofit organization that advocates for quality care for consumers receiving long-term service and supports in any setting. So that includes at home and within the community, in assisted living, and within a nursing home. The purpose of today's webinar is to give you a beginning understanding of what's in the revised federal nursing home rule that the Centers for Medicare and Medicaid Services, CMS, recently released. Because these regulations will impact the lives and care of nursing home residents for years to come, we all need to know what's new and what's remained the same. You may know that our current nursing home rules date back to 1991 when they were promulgated to implement the landmark Nursing Home Reform Law of 1987, which is often referred to as OBRA 87. Since that time, 25 years have passed, and both residents and the nursing home industry have really changed significantly. In 2012, CMS first announced that it was revising the rules in part as a response to an executive order to all federal agencies from the White House to review regulations to identify what was ineffective, outmoded, burdensome, insufficient, and then to modify, streamline, expand, or repeal them accordingly. So 4 years later, we have the result. Hundreds of pages of regulations and comments. So our goal this afternoon is to provide you with a brief and very high level overview of those rules. So next slide, please. On today's webinar, we'll begin by hearing from Karen Tritz of CMS. Karen is the Director of the Nursing Home Division within the Survey and Certification Group of CMS. And we're absolutely delighted to have her with us today. So Karen is going to talk about changes and themes in the final rule, as well as implementation and the survey process. After Karen, we'll present some information from the consumer perspective. We'll give you some preliminary reactions to the regs and then discuss key changes related to a few areas. And those areas will be admission, transfer, discharge, and returning to the facility, staffing, and antipsychotic psychotropic medications. We'll then end with a question and answer session. Aside from Karen, our speakers will be Eric Carlson, who's Directing Attorney with Justice in Aging, Toby Edelman, Senior Policy Attorney with the Center for Medicare Advocacy, and me. Before we start, though, I want to cover just a few logistical details. Right now, all of your lines are muted so that everyone can hear the presentation without a lot of background noise, hopefully without any background noise. We'll answer questions at the end, but if during the time that we're speaking you have a question, you can go ahead and ask it whenever you like just by typing it in the question box, which usually is on the right-hand side of your screen. And also, as you may have heard just a moment ago, this webinar is being recorded, and we will make both the webinar recording along with the PowerPoint slides available to all of you following the webinar. So I think that takes care of logistics. Next slide. So at this point, it's my great pleasure to turn things over to Karen Tritz. Karen.
Great. Thank you, Robin, and good afternoon, everybody. I'm very happy to be with you today. As Robin mentioned, I'm going to talk through some of the key themes in the long-term care rule, but I also want to talk to you a bit about the implementation of the rule and the survey process. to give you some context about how these different pieces will come together. Next slide, please. So as Robin mentioned, the requirements had not been comprehensively updated since 1991, despite sort of significant changes in the industry and in the society as a whole. If you think about where all of us were in 1991, 25 years ago, I think we can all say that things have changed in certain ways, and the new regulations are intended to reflect that. We want to reflect, advances in the theory and practice of service delivery and safety, and also there were a number of sections of the Affordable Care Act that we incorporated into the regulatory framework for the long-term care industry. Next slide, please. So just at a very high level, there are 6 main themes of the long-term care final rule. And as Robin mentioned, the final rule between the comments and the regulation itself is really hundreds and hundreds of pages, 700-ish, I think. But I want to just kind of ground us all in 6 main themes of the long-term care final rule, and we'll walk through each one of these: person-centered care, quality, facility assessment, alignment with HHS priorities, comprehensive review and modernization, and then the implementation of legislation. Next slide, please. So the first one is person-centered care. And there were a lot of existing protections and provisions within the long-term care rule that really framed the individualized nature and individualized requirements for person-centered care, so that the requirement for each person to maintain, attain and maintain his or her highest practical well-being. That was in the language in the 1990s. That language has been retained, and those existing protections are maintained. There's been some additional provisions added in the resident rights section around choice and self-determination and choices around dining and other areas. So that has also been added to the long-term care requirements. There are new sections around care and discharge planning that are more person-centered. So the individual's right to be involved in care planning decisions and to participate in the care plan meetings. The discharge planning section was significantly expanded to ensure that there are good transitions of care, that there's clear information if a facility cannot meet an individual's needs, what those needs are and what was tried. And then finally, an area that's received a fair amount of attention is the prohibition of the pre-dispute arbitration and the requirements for post-dispute arbitration. So this is an area that has received a lot of attention. It received a lot of attention in the comment period and continues to do so. So I'm not going to spend a ton of time here in this presentation on that provision, but it is a very important provision that is in the final rule as well. Next slide, please. So the quality issues still front and center. The quality of care, quality of life. There are 2 sections in the final rule relating to these that have for every service, that cross boundaries through every service. The historically F309, which was the provision around residents achieving the highest practical well-being, had a number of care issues that were historically cited under that arena when there were quality of care concerns. So things like pain management and end-of-life care and dialysis services. Many of those were historically cited under F309, and the quality of care section has now been reoriented a little bit. That language about highest practical well-being is maintained, but there are specific regulatory language related to certain special care issues, such as restraints, pain management. Bowel incontinence was added where bladder incontinence was previously. Dialysis services is broken out as its own item, as well as trauma-informed care as a separate section. And trauma-informed care is actually in a number of different arenas throughout the regulation, from care planning to the quality of care issue that we're talking about now, and then also in the behavioral health services that we'll talk about in a minute. And then secondly, on the Quality Assurance and Performance Improvement Program, that was an area added by the Affordable Care Act that expands on the requirements of the QAA committee and has a requirement that each nursing facility have an ongoing process to identify quality issues, take actions and correct those issues, monitor high risk and problem-prone areas, and take action to correct those areas when there are problems identified. So that's a new requirement for participation that really expands on the existing QAA committee. We did, the Affordable Care Act was unique in that it was one of the first times that technical assistance was provided or was mandated in advance of requirements for participation. And so the agency has been working on that for since the adoption of the Affordable Care Act. And we did a pilot for 17 homes to try QAPI and learned a great deal about what it took to do that, and have a number of resources available on our website, including some self-assessment tools and other areas for providers as they look at advancing the QAPI efforts within their home. Next slide, please. So another theme of the reg is the facility assessment and a competency-based approach. So there's a facility assessment requirement in the administration section, which essentially indicates that facilities need to know themselves, their staff, and their residents, that it's not a one-size-fits-all. It accounts for and allows for diversity in the population, and it focuses on each resident achieving their highest practical physical, mental, and psychosocial well-being. So the facility assessment as a specific requirement was added to the administration section, but it is tied to other areas within the reg, including things like staffing, nurse staffing, dining areas, behavioral health areas, and a number of other areas that really create the expectation that the facility is going to have a good understanding of what's needed in the facility, and then based on that understanding, going to carry forward the requirements. Next slide, please. So another theme is aligning with current HHS initiatives, and I would also argue aligning with current public health initiatives that are relevant for the society as a whole, which is reducing unnecessary hospital readmissions, which within the reg there's a good deal of information around transitions of care and discharge planning to address some of the unnecessary hospital readmissions, reducing the incidence of healthcare-acquired infections. The reg really outlines, it maintains the existing infection control requirements that were in the rule from the 1990s, but adds some key components related to strengthening the infection control program as a whole with surveillance and monitoring of infections within the building. It adds a requirement for an antibiotic stewardship program. It adds a requirement for an infection control preventionist with specialized training. So there's some key pieces added to the infection control area to try and address this issue within the nursing facilities. They've also added an entire section around behavioral health care that incorporates a number of provisions that were previously in other places in the requirement or within the requirements, such as medically related social services, but also incorporates a number of other provisions that really focus on addressing any underlying mental health, behavioral health needs of the residents within the building. So that's an important focus for nursing facilities going forward. And then finally, continuing the work on the use of unnecessary psychotropic and antipsychotic medications. It it expands the definition of psychotropic drugs. It requires a review of the medical chart with the medication reviews, and puts some requirements around PRN usage of these medications. Next slide, please. And then just as an overview, It really did reorganize the reg, as we'll talk about in a minute. There are new regulatory categories. There are provisions that were previously grouped together that have been reorganized into other areas. They've updated it and have made it consistent with current health and safety knowledge. Next slide, please. And there's a number of provisions of the Affordable Care Act that are incorporated into this. Section 6102, which has the Compliance and Ethics Program and the QAPI program. The Section 1150B of the Social Security Act, which has requirements for reporting to the law enforcement and the state agency reasonable suspicions of crimes. The Dementia and Abuse Training requirements, as well as the IMPACT Act, which has discharge planning requirements for SNFs. Next slide, please. So next I'd like to talk to you a little bit about the implementation. So one of the most common comments we got from the proposed rule was that we needed time, that the facilities needed time to implement these provisions, that it was a comprehensive overhaul and there needed to be time to put all of these different things into place. So the final rule takes a phased-in approach to the rule, which is essentially a 60-day, 1-year, and 3-year timeline. Phase 1 is existing requirements, and those requirements that are relatively straightforward to implement or require minor changes to the survey process. So those would be effective at the end of next month. Phase 2 would be all Phase 1 requirements, and then those provisions that providers need a little bit more time to implement, or they may be foundational elements, such as the facility assessment, where we really, we do think that providers may need additional time to figure out exactly what goes into the facility assessment and how does this relate to the other areas of the reg. And then we are also looking for a new survey process that can then assess the compliance with those requirements. And then Phase 3 would be all, it continues all Phase 1 and 2 requirements, but it includes those requirements that would really need more time to implement. So personnel hiring and training, systems approaches to quality, where you may have to realign different pieces. In some cases, there are some structural rewiring things. So, for example, resident call bells at the bedside instead of in the room may need some time to re-engineer within each facility and each bedroom within each facility. So those were put on the Phase 3 timeline implementation. Next slide, please. So this is an overview of what is going to be implemented in Phase 1. There is a comprehensive implementation chart in Section B of the final rule, which goes into quite a bit more detail about what's going to be implemented in each section. But this is just an overview. Where there's an asterisk, it is intended to be, there are parts of this regulatory group that are going to be implemented in Phase 2 and or Phase 3. So, for example, on I'll just take nursing services, for example. The current requirements are for sufficient and competent staffing, based on, or sufficient staffing. The new regulation adds in both a competency-based requirement for staffing and based on the facility assessment. So the facility assessment portion of that will be implemented in Phase 2, but the requirements for sufficient staffing and for competent staffing are effective immediately in Phase 1. So it's just that tying in of the facility assessment piece that would happen in Phase 2. Similarly, for the infection control program, there's pieces of it that are effective immediately. Infection control is an existing requirement. Pieces around linens and vaccinations are current requirements. And other areas such as, for example, antibiotic stewardship that may take a little bit more than 60 days for a facility to implement were moved to Phase 2 implementation. And then those, excuse me, just one second. sorry about that. So antibiotic stewardship would be in phase 2, and then those areas that would require personnel changes, such as the hiring of the infection preventionist, are in phase 3. Next slide, please. Again, this is, it outlines the phase 2 requirements and the phase 3 requirements. So the physical environment smoking policies, there are requirements related to smoking safety now, which are in phase 1, but the explicit policies would be in phase 2, and as I mentioned, the call lights at the resident bedside would be in phase 3. So each section is treated a little bit differently in terms of the provisions and where the implementation falls. So, but the high level is most of the requirements effective at 60 days, a couple of pieces required at the 1-year mark, and another set at the 3-year mark. Next slide, please. So I want to move to talking a little bit about the implementation. So phase 1, as I mentioned, is end of November. We are planning to continue the new requirements, new regulatory language under the current FTAGs. So we will be coming out with a revised version of Appendix PP that has the current regulatory language that is effective, and then has the existing interpretive guidance for that section. But since surveyors cite to the regulatory language, there will still be the possibility that a deficiency could be cited for the new regulatory language, even though the interpretive guidance itself will not be updated. Then in phase 2, November 28th of 2017, we are going to be changing the FTAG numbers. So I know this will be a big change for people, myself included, where you can have full conversations just talking in FTAGs, and that we'll have to all learn a new language together on this. But it was required to have continuity with each regulatory grouping, because as we mentioned, the reg was reorganized, and so we really needed to maintain those regulatory groupings for phase 2. So in phase 2, we're going to be doing new FTAGs, which will start at probably 540 and go up somewhere into the 900s. We're also going to be releasing interpretive guidance changes for all phase 1 and phase 2 tags, and we have taken the opportunity that the reg gave us to really take a second look at our interpretive guidance, and we'll be able to share drafts of that interpretive guidance with stakeholders and others in the coming weeks and months for feedback before we finalize it. But we did want to make sure that now that the regulation had been updated, that we were also taking the opportunity to have our guidance reflect current standards of practice, clarity in terms of what compliance looks like, and just ensuring that we had fully incorporated the regulatory changes. The last change that we're going to be rolling out in phase 2, which is a big one, is we're also going to be bringing the survey process together. So there will no longer be a traditional survey process and a QIS survey process. We are building on the best of both survey processes to have one survey process that incorporates the new regulatory requirements. Next slide, please. So let me give you an example of what this means, just to give you a sense. And just as a disclaimer, this is not a real requirement, so please don't write to the CMS administrator on this, complaining about this requirement. I just want to use it for illustration purposes. So say, for example, the new regulation added a requirement that the facility had to provide purple attire for all residents to wear on Sundays. So it's, just for purposes of discussion. Next slide, please. So for phase one, we are looking at the existing regulatory language and looking at where is the closest fit in terms of regulatory intent. So in this case, it would be F-156, that the facility must inform the resident, both orally and in writing, in a language the resident understands, of the rights, rules, and regulations governing resident conduct and responsibilities during the stay in the facility. So it's not a perfect match, but in terms of intent of the reg, of behaviors, and of activities, we felt like this was the closest. So in the new version of Appendix PP, we would have the new regulatory language that would be effective in F-156. The intent and the interpretive guidance wouldn't change, and the survey process wouldn't change, but there could be, we are going to be training surveyors on this, and it can be incorporated into, the questions, or if complaints came in, that there could be citations related to F-156 because the surveyors cite to the regulations. Next slide, please. So then in phase two, we are not tied to trying to fit it to its closest regulatory intent. We will be breaking it out. So we may then relabel F-156 into F-980 because of the changes to the regulatory organization. And then if it got a new regulatory citation, that would be there. And then if the current language for 156 did not change, then that would still be there. We may, in looking at whatever is there now for F-156, we may say that we could do a better job in explaining the interpretive guidance, or perhaps there were key issues under F-156 that weren't previously addressed that we needed to address. So that would be under the interpretive guidance for the new F-980. And then we're also looking at the survey process to say, is the survey process looking at this tag in the most effective way, and how does that fit with the new survey process that we're developing? So next slide, please. And then similarly, my fake example about the purple attire will also have new guidance and also have new survey process, and then it'll get a new tag as well. And that's for phase two for next year. So our intent is that we will be able to share the tag crosswalks and draft versions of this in advance. Next slide, please. So just have a few minutes left, so I'm going to go through this pretty quickly, but I do want to make you aware that we're also planning to change the survey process. As I mentioned, bring together the quality indicator survey, the traditional survey, the new regulatory changes, and then the work that we've been doing over the last year to 18 months to really study the current survey processes that we have, design a survey process that brings the best of each of these together, and then doing some testing on it around the country. Next slide, please. It's going to be computer-based. We are going to be, it's basically two parts. There's the sample selection part. The surveyors will be walking in with about 70% of the sample using an MDS algorithm that tries to identify where there may be potential areas of concern. And then there's 30% of the sample that the surveyors can select on site. That's expected for them to select on site based on their interviews, observations, record reviews, and they can also substitute the 70% if care issues aren't identified. So there would be a thorough review of the doing interviews of each of those residents and observations and record reviews, and then determining from there which issues need additional investigation. Next slide, please. Again, day one is going to be really interviewing and observing this potential sample, and then at the end of day one into day two, finalizing that sample, and then pursuing any additional investigation needed for any care areas that come up. Next slide, please. So again, we're going to be looking through the investigative process at any concerns that come up. There's also going to, as there is now, there are facility tasks. We're going to be having required tasks for each facility as well as concern-specific tasks if there are specific concerns that come up in the first part of the survey that needs further investigation. And then there's going to, we are using the traditional version of the resident council meeting and having that in all surveys. And then there's a new advanced beneficiary notice, which is what ABN stands for, a new survey process to facilitate the review of those Medicare notices. Next slide, please. So just a couple questions on what training will be available. We are going to have a recorded webinar that is going to highlight phase 1 changes for the surveyors. And we are going to, that will be available, it's designed for the surveyors, but will be available for everybody. And then in phase 2, we're also doing, we'll be having webinars, national provider calls, and then providing some resources related to the new tags and interpretive guidance. And then more details on the survey process will be made available on our website as they are now as well. Next slide, please. So just a couple of resources before I turn it over to my colleagues. Again, the Medicare Learning Network call is next week. It has the high-level information that I just provided, as well as a little bit more detail on each regulatory group. Then in mid-November, as I mentioned, there's going to be a surveyor webinar that's open for all, and we'll be releasing an S&C letter on how to access that, or a survey and certification letter. Would encourage you to continue to watch the survey and certification letters. That's how we communicate with the public on various activities that are going on related to this. And then if you have questions, we have a designated mailbox for any questions that you may have on the rule or the survey process or the guidance as we're moving forward. So I think that's it. If you want to go to the next slide, I think that's it from my end, and would like to turn it over.
Thank you so much, Karen. I think that was a really helpful introduction to the final rule and kind of what lies ahead in terms of implementation and the survey process. There is certainly a lot going on, that's for sure. I'm sure that people will have lots of questions for you, and we'll get to them later in the webinar. Next, Toby, Eric, and I want to talk about the final rule from the consumer perspective. Of course, it's far too early for us to have thoroughly reviewed the new regs, so this isn't going to be an in-depth, detailed analysis. As you can imagine, we're all still plowing our way through the hundreds of pages, reading the rules, comparing them to current rules, analyzing the changes and their impact. So this is really just the first of our analyses, and believe me, there will be many more. So with that said, Toby and I will start by sharing kind of our beginning take on the rule overall, and then the three of us, Eric, Toby, and I, will focus on a few critical areas. Next slide, please. Okay, our preliminary reactions. Consumer Voice's early assessment of the final rule is that it's a mixed bag. There's a lot that we think will promote quality care, quality of life, and residents' rights. And so we're pleased to see that. At the same time, we do find that there are some troublesome provisions, and perhaps of even more concern, no change in some areas where we felt and feel that change was definitely needed. So I'm going to start by highlighting, just again very briefly, some of the provisions that we believe will make a positive difference in the lives of residents. Next slide, please. Okay. So I'm going to go through these pretty quickly. Karen mentioned the ban on pre-dispute arbitration agreements. For us at Consumer Voice, this is really one of the best changes in the final rule. This prohibition is really a gain for consumers by preserving their right to seek justice in the court system in the event of abuse, neglect, or serious injury. And you'll hear more about this later on during Eric's part of the presentation. Person-centered care, Karen talked about it. We are very pleased to see the overall focus on person-centered care that is really found throughout the proposed regs. From our perspective, the rule would require that facilities, learn more about who the resident is as a person and provide greater support for resident preferences. So you see things, for example, like in the assessment process, the facility has to find out about the resident's life, history, and goals. In the activities section, the ongoing activities program must be developed with resident preferences in mind. And of course, food, which is so important. Here the facility has to consider residents' needs, preferences, and the cultural and religious makeup of its population when preparing meals and food. So definitely a strong and welcome focus on person-centered care. The rule also gives residents increased control and choice and promotes and encourages greater resident engagement and participation. So one area where you see that is in the care planning process, where resident control and direction has been expanded so the resident can identify who they want to have involved in developing the care plan, what goals, outcomes of care, and the type and the amount and the frequency of care they want. And facilities are explicitly required to support and facilitate resident involvement in the planning process. So we think those are very welcome provisions. In addition, we're definitely pleased to see that a number of residents' rights have been strengthened. There are many examples, but I'm just going to give you three quick ones. First, the rule now calls for a robust grievance process with a person designated as a grievance official who must investigate and prepare a written decision about the findings of that investigation that has to go to the resident who filed the complaint. Second example, the facility is explicitly required to act as a fiduciary of residents' funds. It's prohibited from waiving its liability for the loss of residents' personal property, and it also has to exercise reasonable care for residents' belongings. And so we're really glad to see these new provisions. And third, there are greater protections against involuntary moves within the facility. The facility has to give written notice of a move from one room to another, has to tell the resident why he or she is being moved, and the resident will now have the right to refuse a move if the purpose is solely for staff convenience. Another critical area that's been strengthened is abuse and neglect. And we're very glad to see that exploitation is now included and that facilities will not be permitted to hire licensed individuals, for example, like nurses, with a disciplinary action against their license. And they must report suspicions of a crime to law enforcement. This comes from the ACA, and we're glad to see that it is now in regulation. And finally, just among many, there's the addition of a baseline care plan to be created within 48 hours of admission. We think that's really positive. A new section on behavioral health, and enhanced training requirements that I'll talk about a little bit later. So we think that those, again, at a high level, are just some of the provisions that will improve the care and the lives of residents. So now I'm going to turn things over to Toby to share some of her thoughts about the positives. Toby?
Thank you, Robin. I wanted to focus for a couple of moments on the preamble to the requirements of participation. The preamble is the part in the Federal Register that precedes the regulatory language, and it explains in that section of the Federal Register publication, CMS explains the changes that it proposed and why, the comments that it received and how it responds to those comments, and then the final decisions that it made. So it's very important in the preamble that I think CMS explained very clearly its intention that in revising the requirements in this comprehensive way, it wanted to make sure that the rules protect resident health and safety. It described quality of care and quality of life as two distinct and overarching principles that govern the regulations. It says all residents' rights that currently exist are retained in these new final requirements. It says resident care should be person-centered, residents should have access to information, and that the inappropriate use of psychotropic drugs should be decreased, if not totally eliminated. These are all extremely positive statements, and they reflect CMS's recognition that the rules that they publish have to implement and fulfill the 1987 Nursing Home Reform Law. That law described the duty and responsibility of the Secretary to assure that the requirements of participation and their enforcement are adequate to protect residents' health, safety, welfare, and rights. And the 1987 Reform Law also established an entitlement in each resident to receive all the care and services that the resident needs in order to attain or maintain the highest practicable physical, mental, and psychosocial well-being. These are high expectations and mandates, and CMS acknowledges that the rules are required to implement this statutory directive, and I think we certainly heard that from Karen as well in her presentation, recognizing the importance of the reform law and the individualized care for residents. So that is a theme that runs through the preamble that I wanted to stress as a positive, and it was on this page and on the following page where I just put in some of the actual language from the regulations that I think sets out these points. I'd like to return the webinar back to Robin.
Thank you, Toby. Next slide, please. So we've certainly recognized that there are many positives, but as I did say earlier, we do have some concerns. While we're very glad to see the positive changes, there are a number of issues that are definitely troublesome. And I have to say that from the perspective of the consumer voice, our absolutely greatest concern with the revised rule is that it fails to address what we see as the biggest problem in nursing homes today, which is inadequate staffing. The lack of enough nursing staff is just the #1 complaint about nursing homes that we at Consumer Voice hear from residents, families, and advocates on a daily basis. Yet, the new regulations don't include a minimum staffing standard or a requirement for a 24-hour registered nurse. And so with no floor below which staffing cannot be cut, there's nothing to stop nursing homes from cutting staffing to dangerously low levels. And in fact, many nursing homes that are owned by corporations or private equity firms are in fact incentivized to do just that. And the absence of a registered nurse, 16 hours basically a day, because they're only required to be there 8 hours a day, really, we think, places residents' lives at risk. I mean, registered nurses are the only nursing personnel with the education and the licensure to do, physical assessments, interviews, record reviews, so that they can draw conclusions about nursing diagnosis, carry out appropriate nursing interventions, and then monitor and evaluate those interventions. And while we absolutely acknowledge the incredible importance of licensed practical nurses, the assessments are something that are within the scope of practice of RNs and not LPNs. So this high level of skill and knowledge for oversight and care is really needed 24 hours a day, 7 days a week. When you only have RN coverage for 8 hours a day, we're very concerned that that really undermines effective prevention of complications and can delay important interventions. And then we think about a situation where the absence of an RN, maybe at 3 a.m. in the morning, means that there may be or is no one present who can assess and respond when the resident's medical condition suddenly changes or deteriorates. So we're quite concerned that without detailed, explicit staffing standards and the assessment, intervention, and treatment skills of an RN round the clock, that nursing homes won't be able to meet the ever-increasing needs of frail elders and individuals with disabilities who live in those facilities, and that it's going to be extremely hard to comply with many of the proposed regulations, such as infection prevention, for instance, that are quite good, but you have to have enough staff in order to implement them. Instead of specific staffing requirements, CMS is taking an approach, as Karen noted, that's based on competencies and on a facility assessment. We certainly don't think that that is a substitute for staffing standards, but we think there's the possibility of using the assessment to try to meet residents' needs, and we will certainly be advocating for this assessment to be implemented and enforced in a way that truly benefits residents. So, staffing, our #1 concern. Now I'm going to turn things back over to Toby to talk about a few other concerns.
Thank you, Robin. I certainly agree with Robin fully about the critical importance of nurse staffing, and it seems to me that the promise of the preamble and of the '87 nursing home reform law itself can be achieved only if we have adequate and sufficient staffing in nursing homes, including nurses. But I want to talk about a couple of other themes in the preamble that gave me some concern as I was reading through it. CMS calls for a lot of flexibility in the regulations. It says it's deferring detail about some of the requirements to the interpretive guidelines. It says repeatedly that it wants to avoid burdensome requirements or overly prescriptive rules. And CMS also says repeatedly in the preamble that it's encouraging facilities to do certain things or expecting they will do certain things, but not explicitly requiring those actions. I think the positive interpretation we can get from this and from the facility assessment that Robin was just describing and discussing, and Karen as well, is that CMS is telling facilities that they have to figure out for themselves with their professional staff that they know how to take care of residents, and we are expecting them to use their professional expertise, their knowledge, their experience, and their knowledge of the individual residents to make sure residents get the care they need. CMS also suggests in the preamble that's of concern to me is that they are deferring some issues, maybe will have possible future rulemaking. And I think there are two that we could identify now that we might be interested in additional rulemaking in the future. One is the care of residents with dementia. CMS added a very small section to the new behavioral health requirement of participation using the word dementia, but there are no details. The CMS has had a dementia care initiative for the last 4 or 5 years and has given facilities a lot of important information about how to provide better care to residents who have dementia. Those pieces of information have not made their way into the regulations, which we thought would be more helpful. So we will be monitoring implementation of the rules and the interpretive guidelines, but dementia care may be one area for future rulemaking. A second area is social workers. CMS anticipates appropriately a lot of social services activity in the area of discharge planning that both Karen and Robin highlighted. But CMS did not make any changes in social worker standards. The reform law was pretty limited in this regard, and it said that a facility with 120 beds has to employ a qualified social worker on a full-time basis. But what it did in the final regulations is move the existing social worker requirements from the current quality of life rules to two new places, the behavioral health requirement and the administration. So the current requirement is scattered but not strengthened. CMS acknowledges in the preamble that it has authority to require smaller facilities to employ a professional social worker. And with the increased expectations for social services in nursing homes, we think that's going to be appropriate. So this is a second area that I think we will be monitoring very closely and maybe supporting additional rulemaking. I wanted to make one final point about the preamble. CMS explicitly expressed concern. It said it was troubled that some of the comments submitted to the proposed rules reflected a misunderstanding of current requirements of participation. CMS provided a couple of examples of what it called, quote, notable misconceptions. The first was the resident's right to choose a personal physician. There were comments challenging that proposal. CMS said, it's been a requirement for 25 years. This is not a new standard. The second area CMS identified was the requirement that an RN be a member of the care planning team. That is also required and has been required for 25 years. And CMS was troubled, as it should be, that some commenters did not know that these requirements are current standards. I'd add a couple of other requirements that commenters apparently made similar complaints about in commenting on the proposed rules. One was the equal access to quality care. That's the requirement that the facilities implement identical policies for transfer, discharge, and covered services without regard to source of payment. So no discrimination against people who are using Medicaid for transfer, discharge, or services that are covered by the program. Another current standard that commenters were concerned about and objected to is the requirement that physicians consult immediately with the resident's physician when a resident experiences a significant change of condition. These are both critical, longstanding requirements. As CMS says, and as Karen said this afternoon, many of the requirements, in fact, most of the requirements that are in these requirements of participation become effective November 28th. They're already the standards of care. There may be some word changes, but many are identical, and certainly the requirements are current. And we need to hold facilities accountable for meeting them now, not saying we have new requirements, we can't be expected to do this. A lot of it is unchanged. So that's a concern from the comments that people submitted, indicating quite a bit of confusion about what's been required for a quarter of a century. Back to you, Robin.
Thanks, Toby. Next slide, please. Okay, now we want to take a look at a few specific aspects of the final rule, do a little drilling down, keeping in mind that, once again, this is based on an initial review and that more analysis certainly needs to be done. Next slide, please. So, Eric, I'm going to turn it over to you.
Thanks, Robin. I'm going to talk about admission, transfer, discharge, returning to the facility. The vast majority of these provisions are in the new section 483.15, with the exception of the arbitration provision, which folks can find in the administration section at 483.70. So, first, arbitration. The proposed rules came out a little over a year ago, and at that time CMS asked for comments on whether pre-dispute arbitration should be barred. The proposed rule didn't have that provision, but CMS inquired as to whether that was advisable. Took thousands of comments on that issue, and CMS came to the conclusion that yes, pre-dispute arbitration should be banned, and that's what's in the current regulation. And the reason is because, as CMS concluded, that arbitration had a negative impact on quality of care. It's important that residents be able to pursue whatever legal remedies might be available to them, and their ability to do that is a right that they have, and some leverage that they have to improve the quality of care in facilities. Just to make a distinguish here between pre-dispute and post-dispute, which is extremely important here. Pre-dispute essentially means, as a practical matter, at the time of admission. People enter a nursing facilities, they're given an admission agreement. Somewhere in that admission agreement, it talks about folks committing to arbitration rather than being able to file a lawsuit. And in pre-dispute agreements, people, as part of their admission, forfeit their right to seek remedies in courts and obligate themselves instead to pursue disputes in the arbitration process. From a consumer perspective, this is generally negative. The process is set up in such a way that's oftentimes disadvantageous to consumers. But the most important point I'd like to make here is to distinguish between pre-dispute and post-dispute. A lot of industry folks in defending arbitration will say, oh, it's cheaper, it's better, it's more efficient. We can argue about that. I think that's wrong. But the important thing is people should be able to make that decision affirmatively and with their eyes wide open and with knowledge as to what they're doing. No one, when entering a nursing facility, their first thought is, oh, I want to make some decisions of what kind of forum my disputes will be adjudicated in. It's just not consistent with the real world to think that that's what's really happening. So that's why it's unfair, and that's why CMS draws this distinction, and that's why under the regulation, post-dispute arbitration is allowed. It's completely fine after a dispute arises for the resident, likely the resident's attorney, and the facility's attorney to decide to handle the dispute, to have it adjudicated however they choose. But that's very different from committing people to something that they signed at the time of admission, likely without paying much attention to it. So that's the provision. It's effective as of the end of November. I'll note that the American Healthcare Association and some of their facilities have filed a lawsuit challenging this prohibition. It's filed in federal court in Mississippi, and there's no result yet. So there's not surprising. They just filed a few days ago. I'll note that CMS, I would say, clearly anticipated that. It's a good read as preambles go to take a look at the discussion of this in the preamble. CMS goes to great detail to talk about their legal justification in establishing this regulatory provision, and also talking about the public policy rules which support banning pre-dispute arbitration but allowing arbitration agreements to be entered into and enforced post-dispute. Next slide, please. So a couple other admission issues that I'd like to talk about. One is the financial guarantee prohibition, which is long-standing in the nursing facility law. This is part of course, the nursing home reform law that has prohibited guarantee agreements from being required as a condition of admission or continued stay. One step forward in the new regulations is the addition of language that makes it illegal, that doesn't allow guarantee agreements whether they're required or requested. In some instances, facilities have used agreements that claim that the person is just volunteering to take on financial liability, that the family member, usually an adult son or daughter, but sometimes nephews, nieces, sometimes neighbors, other people who may sign an admission agreement and find themselves financially liable. So there's an improvement here, and it eliminates facilities to try to sneak around this by claiming that people have volunteered to become liable, because the new language establishes this prohibition whether the financial guarantee has been required or whether it's just listed in the admission agreement supposedly on the grounds that the person is volunteering to do that. I'll note that this doesn't solve all of the problems of nursing facilities trying to establish financial liability on other people, whether they be family members or friends or whomever. It doesn't address the situation where people end up getting sued because they agreed to handle the resident's money and are then sued individually for failure to do that properly or failure to make sure that the resident's Medicaid application was handled appropriately. CMS notes that. They certainly received comments on that issue and says in the preamble that they'll take a further look at this particular issue. Next slide, please. There's a general provision that's of some use here that says that in the regulation that the terms of admission agreement must not conflict with these regulations. So that may be very useful. My experience in the past has been when complaints are made regarding the language of admission agreements, I have seen certainly multiple times in the past where admission agreements claim certain things that are inconsistent with the regulations, and the response from the surveyors is, well, not our problem, that we don't, admission agreements are not our thing. We don't have any jurisdiction over that. And that's no longer true under this regulatory provision. Next slide, please. Let's talk about transfer discharge a bit. The core requirements certainly are the same. It's still set by the nursing home reform law, of course, by the statute. There are only 6 justifications for involuntary transfer discharge from a nursing facility. I'll point out some changes in language here. The safety of others justification, that is people being involuntarily transfer discharged supposedly to protect the safety of others, is now limited to endangerment due to the clinical or behavioral status of the resident. I'm not sure if that's a huge help, because oftentimes it's oftentimes the resident's behavior that is cited as a justification, but folks should understand that limitation exists and see if it could be of some use. Something that's likely of more use is this additional requirement relating to non-payment that says that non-payment is not in play if the resident has submitted necessary paperwork for a third-party reimbursement. This is oftentimes an application for Medicaid coverage, and so there shouldn't be non-payment as long as that Medicaid application or some other application for third-party reimbursement is in process. This is a requirement that used to be part of the surveyors guidelines, but now has been moved into regulation, which is a positive thing. Next slide, please. This is another change in language. I do think that this could be extremely useful. It deals with the claim transfer discharges that are justified by the claim that supposedly the facility can no longer meet the resident's needs. And I've seen dozens, hundreds, thousands of these. And there's some important limitations here. Under the new regulations, the medical record has to include the specific resident needs that cannot be met, a documentation that the facility has tried to meet the resident's needs, and this could be really useful, the service available at the receiving facility to meet the needs. I've seen plenty of these kind of cases in the past where the facility is essentially, a little bit of editorializing here, tried to push out residents just because they're difficult, relatively heavy care, bothered for some reason, and this is going to do a much better job of forcing the facility to fly straight on this issue, to actually try to deal with the residents' needs and explain why supposedly the second facility is better than that initial facility to meet that needs. I'll note a related requirement here that pre-admission the facility provide notice of special characteristics or service limitations. this cuts both ways. I know a lot of us in comments didn't particularly like this provision because it suggested that maybe facility would have the right to self-define their level of care, which in a way that would be too narrow. CMS helpfully in the preamble said, no, that's not the intent. That's not what this is about. And what this could be useful for is addressing claims that the facility can no longer meet somebody's needs. I think there's a good argument here to say if the facility didn't give notice of those special characteristics or didn't give notice of those particular service limitations, the facility shouldn't be able to cite such purported service limitations down the road in trying to force people out. Next slide, please. Some new protections. Explicit provision which says there's no transfer discharge as long as the appeal is pending, which of course makes perfect sense. It hasn't explicitly been in the regulations until this point. And an additional provision which is clearly new, the facility is required to send a copy of the transfer discharge notice to the long-term care ombudsman program, which will give the ombudsman program much more ability to deal with these situations. In my experience, oftentimes a big problem is that residents just don't have the support and they capitulate when they get these notices. And if long-term care ombudsman program have the resources to get in there and support people and help them, that'll go a long way to limiting inappropriate transfer discharges. Next slide, please. And then very quickly we'll talk about returning to the facility. Some of this is the same. The facility has to give a notice of its bed hold policy. It has to allow the resident, a Medicaid eligible resident, to return to the next available room. And the new provision says that the has to be the previous room if available. And then moving on to the next slide, let's talk about resident dumping in relationship to this for a second. There's one ongoing problem here is that sometimes when residents go to the hospital, the facility refuses to take them back. And it's a difficult situation for residents for obvious reasons. From the consumer advocate perspective, facilities are trying to evade the transfer discharge provisions just by essentially locking people out just because they happen to be hospitalized. The new regulatory provisions state that the facility has to comply with transfer discharge regulations in these situations if the facility determines the resident cannot return to the facility. And there's also some very good language which points out that CMS doesn't anymore talk about readmissions, instead talks about returning to the facility. And I think that's a message that I'm going to take to heart, and I would encourage other people to pay attention to as well. People shouldn't have to be or aren't being readmitted just because they go to the hospital. They're returning to the facility, and that's the attitude that facilities should take and resident advocates should take as well. That you shouldn't, as a provider, get a free pass around the transfer discharge rules just because the person happened to go to the hospital. Those rules are still in effect. So with that, let me turn control of the conversation back to Toby or Robin to talk about some other key areas.
Thank you so much, Eric. That was chock full of really helpful information. I am conscious that our timing is that we're getting to the end of our time, and what I'd like to do is ask permission both of our speakers and of all of you who are participating to go a bit longer. And with your permission, we will finish up our presentation, albeit perhaps a little faster than we might otherwise have done, but also then go on and have a question and answer time, and we would anticipate not going past 3:30 at the very latest, but we do want to make sure to give you a chance to ask at least some of your questions. There's some really good questions coming in. So thank you in advance. we wanted to cover a couple of other key areas. So, of course, staffing is a very important area, as I pointed out earlier. So I'm going to talk about, very briefly, about staffing levels as well as staff training, and I'm going to also kind of talk broadly about staffing, so I'm covering not just nursing, but behavioral health services, activities, social services, and food and nutrition services as well. So in terms of levels and numbers, there are certainly no required minimum staffing standards or increases in staffing levels anywhere in the regulations. But there are some areas where there is new language. Next slide, please. Okay, so wanted to kind of compare and contrast some of the different areas related to staffing. So in terms of activities and social services, there is no change in the staffing language except in terms of qualifications for those providing activities and social services. And just as a reminder for social services, the current regulation, which will continue, is that there be one full-time social worker in facilities with over 120 beds. And for activities, the regulations just say that there is an activities program that's led by a qualified professional. So no changes there, but there are changes in the language related to nursing, food and nutrition services, and this entirely new section, behavioral health services. So Karen referenced this earlier when she was speaking. When you look at these areas, they call for sufficient staff, but based on and with appropriate competencies and skill sets as determined by resident assessment and individual plans of care. That has already been the standard in terms of plans of care for nursing, but new for food and nutrition and behavioral health services. And taking into consideration the number, acuity, and diagnoses of the facility's resident population in accordance with the facility assessment. So here, the key is that you have staff with appropriate competencies and skill sets, and that you take into consideration and use the facility assessment to really kind of determine what that sufficient staff is and what competency levels they need to have. So I will add that this language also applies completely to behavioral health services. So next slide, please. So the assessment is how the facility determines what resources are needed to competently care for residents. The regulations call for the assessment to be reviewed and updated whenever there's a significant change, and at least annually. Next slide. So among the things that the facility has to look at to develop this assessment are its residents. So the characteristics of its resident population, and you can see listed on the slide the factors that the facility has to take into consideration in terms of the resident population. On the other side of the slide, the facility also has to look at its facility resources. And again, you can see the things that they have to take into consideration, such as buildings, vehicles, and also personnel and their education and training. So the assessment is, in essence, what defines sufficient. It tells the facility the number of staff it needs, as well as what competencies and skills are needed to provide care for residents in a way that's individualized and in a way that will attain and maintain the highest level of well-being for each and every resident. Next slide, please. So the second aspect of staffing I just want to touch on is training. There are some significant changes in this area. For the first time, facilities have to have an ongoing training program for all staff. And that includes both existing and new staff, and also contract employees and volunteers. So that's all new. Next slide, please. So the final rule also lists some of the topics that must be included in the training, and you can see those topics listed out here. However, the regs don't say what type of training or how much training must be provided. That is, again, to be determined by the facility assessment, which, again, I think underscores the importance of this assessment and how much it really is contributing to the operation of the facility. Next slide, please. So in addition to this training requirement for all staff, the in-service training requirement for nurse aides has been revised, and it's been revised to include dementia management training and resident abuse prevention. And this, again, goes back to the ACA, which called for this to be included in regulation. So now, Toby, I'm going to turn things over to you. I realize that we're going relatively quickly here, but if certainly want to make sure that you have time to talk about the very important issue of antipsychotic and psychotropic medication.
Thank you, Robin. I will try to go through this very quickly so we have time for questions. Antipsychotic drug rules currently are part of the unnecessary drugs that are part of the quality of care rules. The unnecessary drugs has a subsection on antipsychotics that says a resident should not get an antipsychotic drug unless it's necessary to treat a specific condition that's been diagnosed and documented, and even if it is appropriately prescribed, there should be gradual dose reductions and behavioral interventions. Antipsychotic drugs are a very serious issue. They've been a serious issue in nursing homes for decades. Most recently, about 5.5 years ago, the Inspector General issued a report indicating that, finding that most of the residents who were getting antipsychotic drugs should not be getting them. They were medically inappropriate, and we know from the Food and Drug Administration, which has given a black box warning, highest level of risk for these drugs. They can kill or harm residents who are given them if their diagnosis is dementia. Since the Inspector General's report, CMS had an initiative on antipsychotic drugs, which it now renamed the Partnership on Dementia Care, and there has been a reduction, but still we have more than 200,000 people getting these drugs. So it's very important what these rules say for residents. Next slide, please. The changes in the new regulations are very significant. First, CMS moves unnecessary drugs and the antipsychotic drug rules from the quality of care regulations to pharmacy services. In pharmacy services now there's a new broader category called psychotropic drugs, which are defined to include antipsychotics and also antidepressants, anti-anxiety, and hypnotics. The current protections for antipsychotic drugs are applied to all psychotropic drugs. Next slide, please. There are also new rules that we've never had before about PRN, as needed psychotropic drugs, and you'll see that there are slightly different rules for psychotropic and for the subcategory of antipsychotic. Next slide, please. The preamble explains how CMS modified the definition of psychotropic, different from what it had proposed. The proposed regulations would have included opioid analgesics and an expansive any other language category. Now the psychotropics are listed or are restricted to the 4 drug categories, although CMS is reserving the right to add other drugs in the interpretive guidelines. CMS also talks in the preamble about why it declined to incorporate requirements from 1992 proposed rules that were never made final about antipsychotic drugs. Those issues included such proposals as informed consent. CMS says now it didn't repropose those requirements because they were too prescriptive. Another change from the proposed rule was with respect to the PRN. The proposed rule allowed PRN drugs for only 48 hours. Now the final rules have made it 14 days because it considered the 48-hour proposal too burdensome for facilities. Next slide, please. This is the last point I just want to talk about, drug regimen review. The current rules require a monthly review of each resident's drug regimen by a licensed pharmacist, and the pharmacist is required to report irregularities to the attending physician and the director of nursing. The new rule adds some new requirements. The pharmacist must include a monthly review of the medical record of the resident every month, as it does its drug regimen review. That seems like a very positive and important change. And the irregularities now will need to be reported to the medical director in addition to the attending physician and director of nursing, with CMS recognizing that the medical director sets and oversees healthcare, medical care in the nursing home and should be informed about irregularities. The physician is also going to be required to say what, if any, action the physician has taken to address the pharmacist's report of irregularity and explain the rationale if the physician refuses to accept the recommendation of the consulting pharmacist. And facilities now have to have a policy and procedures about drug regimen review. Next slide, please. Last slide. The preamble makes clear that it accepted the public comment to require pharmacists to review these medical records monthly. The proposal has been 6 months, so this is a tightening up of the requirement in response to public comment. That's good. But it declined, CMS declined the comment to require that residents and their families, their representatives, be given copies of the pharmacist's report of irregularities. CMS says maybe nothing needs to be changed, and so families shouldn't be getting those reports as a matter of course. It affirmed its proposed recommendation that the medical director be informed of the irregularities, but it declined the comment to require that consultant pharmacists be independent. That was a proposal made in 2011, which CMS declined to make final. At that time, in 2012, said might reconsider, but CMS has not reconsidered that proposal in these final regulations. So, Robin, back to you. I hope we have time for questions now. Thank you.
Toby, thank you, and Eric and Karen. Really appreciate all the information you've provided. Great information in a short period of time. So yes, we do have time for questions. And just as a reminder, if you would like to submit a question, use the chat feature and type your question into the question box. We have received some questions as we've been going through. So I want to introduce Lori Smentanka, who is the Executive Director of Consumer Voice, who's been assisting with the webinar and has been a great help with identifying and looking at the questions. And she is going to, I think, Lori, did you say you'd be willing to read the questions and we'll work to get them answered?
Yes, I'm happy to do that. So we've gotten a number of really terrific questions in, so thank you all for your participation today. A lot of them are quite detailed and specific about sections of the regulations, and so I think it's going to be challenging to get to a number of those. So I'm going to start with the general ones and see where we get. And we will send all of the questions to CMS so that they have responses, they have access to them. And I guess the first question around that would be, Karen, are you all planning to do a frequently asked questions section, or how can folks also send questions to you?
Sure. So first, thank you very much for giving me the opportunity to talk with you today. I do think, so a couple of thoughts I have on this. One, I think, Lori, if we're not able to get to all the questions today, please feel free to send me whatever questions you've received related to my areas. I'm happy to take a look at them and look at responses there. The mailbox that I mentioned is also another source if folks have questions later and want to send that. That's the
surveydevelopment@cms.hhs.gov mailbox, and that's another option as well.
Great. And Karen, can you also tell folks again how to access the call on the 27th, how they can get information about that? There were a number of questions about that.
Great. So honestly, I would do the following. I would search on your favorite internet browser, MLN calls CMS, which should take you to the home page. They're also known as national provider calls. And then when you do that, it should take you to a list sorted by date of upcoming MLN calls, and you're looking for October 27th, and it'll say requirements of the new long-term care rule.
Okay, great. Karen, if you could keep your line open for another, there were several questions, several people asked the question about when will a single document that contains all of the new regulations be available for download instead of having to go with the new Federal Register and then compare to the old one? Is there a plan for having the combined final version available online?
Yes. So we will we are in the process now of incorporating the new regulatory language into Appendix PP, which will be an advanced version. That will have the old language in black and the new language in red for all Phase 1 requirements. In most cases, we will also be including Phase 2 requirements because they're somewhat central, and it can be awkward to pull out those things. So in most cases, we will have that as well. But we are also considering a regulatory document that would be available that has Phase 1, 2, and 3 with the text in black that is existing language and the text in red that would be new language. And it sounds like that's something that would be helpful to folks.
Absolutely. Okay, so let me start digging into a couple questions. I know we're really limited on time, and I will say that most of the questions we received were in a few subject areas, including arbitration, staffing, residents' rights, discharge rights, and assessment. So I guess the other thing I'd like to say is that not only will CMS be continuing to put out guidance, but we at Consumer Voice are working with Eric and Toby and other advocates, and we'll be releasing some additional information and issue briefs as well for our networks. So one question that came in for Karen, there's a lot of focus in the rule on QAPI and facility self-assessment and competency-based approaches. There's also increased efforts to ensure person-centered care. So can you talk about what requirements there are, if any, for residents and their representatives, including ombudsmen, to be included in and/or have concerns responded to in these QAPI self-improvement efforts?
Yes, so the consumer's role in QAPI, or the resident's role in QAPI, is an important component of the reg. The QAPI plan will have to include sort of methods for involving residents in that process. When we did the pilot, we had an evaluation of the 17 homes that tried to do QAPI. There were a lot of lessons around not only what it took to do QAPI, but one of the big takeaway lessons was how to meaningfully engage residents in that quality improvement plan and activities, and to identify what are those performance improvement activities that are appropriate and relevant to residents in that building, and how do you address that. So certainly through the resident or family council would be an appropriate way to highlight those things, the grievance and appeal process strengthening, and then I do see a strong role within QAPI for residents to have a voice about those quality issues that are most meaningful to them, and to be able to have information
from the facility itself about where they're going with the QAPI.
Great, thank you, Karen. And I think we probably have time for just one more, and I'll ask a more general question again. How are the phase 1, 2, and 3 implementations going to be monitored? Is there going to be enforcement action, or how is CMS and the state survey agencies going to monitor those implementations?
So the monitoring will take place through the survey process. So we are going through the long-term care rule requirements now and looking at what was added, what changed, and what in the survey process, how best to identify compliance or non-compliance with that section. So for example, on the infection control area, it is a facility task that is done in every facility. Right now, they look at broad parameters of infection control activities, but we are looking to revise that to make it much more specific in terms of the, what is appropriate antibiotic stewardship programs, surveillance, monitoring. So the monitoring of compliance with all the phase 1, 2, and 3 requirements will be built into the survey process and then they'll have tags associated with them, and then the enforcement processes will flow accordingly from that.
Mm-hmm. Great, thanks, Karen. So we're at 3:30. I think for interest of time, and again because so many of the questions are so very detail-oriented, as I mentioned earlier, we will share these with CMS, and this is just the first of our efforts to get information and education out to you all on these regulations. There will be more coming, not just from us, but also from CMS. And Robin, I'll turn it back over to you to close us out.
Okay, thank you so much, Lori. As you can see on your slide, and as Lori mentioned, help is on its way, so stay tuned. We've already started working on a number of resources to help you learn what's in the regulations, and those will be coming your way over the next few months, and we certainly plan on doing more webinars. Next slide. So in the meantime, here's our contact information if you have questions or if we can help in any way. So I want to thank Karen, Eric, and Toby for such wonderful and helpful presentations. And I want to thank all of you today for taking the time to join us to learn more about these incredibly important regulations as we all start to get to know them and understand them. So thank you so much. Stay tuned and happy reading. Lots to work our way through. Take care.
Thank you.
Thank you.